Today's session is about understanding patients' expectations. Very often we say that patients' expectations are unrealistic, they really expect a lot, they're very demanding, and we feel that we are not able to, sometimes really, fulfill those expectations, and they feel disappointed with the way we handle them. So today we are going to discuss at length about what are the usual expectations of the patients. Then if you really want to, sensitize your staff, because that's where we, you know, feel extreme challenge that they would do everything, but then they would not do as per the expectations of the patient. A lot of time we get complaints from the patients for silly reasons that they didn't allow me to do this, they did not listen to me, or nobody responded to me, and I had sent a message, but I did not receive any information. So, I mean, it's very disappointing sometimes when you get these kind of, complaints and issues that coming up to you. So to sensitize your staff, I think we really need to, talk about this topic at length. And I think individually, personally, we should also understand patient expectations in detail. So before I actually start with this session, I would actually take you to an activity. So if I may ask you all to be sitting comfortably, have your copy and a pen in front of you. And I'll be giving you a set of instructions, and I would be taking you through a journey, and certain points you will have to note down simultaneously, because we are trying to understand the patient's expectations. So if I may start, imagine that, is everybody ready with a copy and a pen and you're comfortable? Okay. And if you can have your camera on, that will be really nice. I would repeatedly request that please keep your camera on, because if I can see you, I can connect with you. That's the only way. Otherwise, I will forget that you are there. I'm sorry. I know you may think it is wrong on my part, but then that's how the whole thing functions. Visually, we need to see the person to connect. So please keep your camera on, stay connected with me, so that I know that you are there and you also would be able to connect with me. Okay, so imagine that I'm taking you through a process. So it's a visit to your own hospital OPD, especially those who are working in hospitals or your own clinic. But those who are not from any clinic, you may just imagine that you are visiting a hospital to an OPD. So while your visit, what you have to look at is, what do you think are your expectations or needs or requirements, and are they fulfilled or not? So I'm sure you are well versed with your own setup. You have an idea what facilities and arrangements you have in your hospital. So keep those things in mind. And now you start your visit. Imagine yourself entering the hospital gate for an appointment with your doctor. So a special thing here is that you are not an hospital employee. You're not part of the hospital. You're not a doctor or a nurse or a healthcare provider. You are a patient there. So imagine yourself, expectations from the point of view of patient. Absolutely, sir. That's the idea, that you are a patient in this case. And you have entered your hospital. See yourself parking your car. So now think of where you normally park your car. Since you are not a hospital employee, your parking fellow does not know you. So see what kind of behavior he is exhibiting towards you, because you are not a hospital employee. So he's treating you like an outsider or a visitor. And check your expectations from that parking person, and see if your expectations were met or not. So maybe if your expectation is met, you can write tick, and if it is not met, you can write cross. So that will give you an idea that how many expectations of yours were really met. So it could be expectation, it could be requirement, it could be need or your desire, whatever it is, all that will be a part of the expectation. Now you have, parked your car and you are moving towards the reception to confirm your appointment and the availability of the doctor. So you get to know that your appointment is confirmed, but you'll have to wait. because your doctor is with another patient, and how much time it will take. There are few more patients before you. You went there in spite of, you went after taking an appointment, but in spite of that, you have been asked that have to wait for good half an hour to 45 minutes. And now you, see yourself waiting in the waiting area. And it's going to be almost like 30 to 45 minutes. Now, check your expectations in terms of the, your interaction with the receptionist who confirmed your appointment and who also told you that, sorry, you'll have to wait for 45 minutes. Again, check, is your expectation met? Was it the right way that she did? See yourself in the waiting area now. You are, looking at the waiting area, look at place to sit. You know how busy your OPD is, how clean your OPD is, how ventilated your OPD is, how comfortable your OPD is. Now you are looking at the OPD and you're looking at a place to sit down. So depending upon your expectation or the reality, just note down, is your expectation met? Are you satisfied with that or not? Are you also okay with the waiting time? Because that's what she said, but then are you okay with that? Again, say yes or no, you can write in your diary. Now your turn comes for consultation. You visit your doctor, and if you are not working in the same hospital, naturally you don't know the doctor. You're visiting him or her for the first time. Look at the quality of interaction that you experience with your doctor. Try to, observe the quality of interaction that you're having with your doctor. And were your expectations met? Were you given what you expected? Were you given a chance to ask questions? Were you given a chance to ask questions? Were you explained as per your requirement? So try to, visualize all those things. And again, if you think your expectations were met, Mr. Mohan, do you wish to say something?
Ma'am, what if my answer is 50-50?
You can write 50-50.
Thank you.
You can write 50-50. It's okay. But they were not fully met. So otherwise it would be cross, but then if you say 50-50, then that's okay. Okay, so now you have come out of the doctor's chamber and you have been asked to do some blood test, some lab work. So you go to the lab and now you see the lab person, whoever is on the reception or the technician who's going to take the sample from you. Just look at the quality of interaction you have with him, the facilities available for the waiting, for patient to sit, for patient to, in case need to go to the washroom for collecting urine sample or other sample. So look at the complete, setup of the lab and the behavior of the lab technician, overall interaction with the lab technician. Again, check your requirements, your needs, your expectations. If they were met, right, met, otherwise maybe no, or like Mr. Mohan says, 50-50, even that's okay. Even that's another good way of, expressing how satisfied you are. Now, after the lab work, you go to the pharmacy to collect the medicines that your doctor has prescribed. Try to focus on your expectations from the person who is dispensing the medicines. Did he explain you? Did he answer your questions? Was he in a hurry? Did he or she give you a chance to ask questions? How many tablets, how many times, how many days, any allergy, any risk or cost factor or brand factor or discount factor? I mean, all that when you have with your pharmacist. Again, look at the interaction, quality of interaction and your requirements. Was that met or not? Right, yes or no, whatever your thought is. You're going back to your parking area because you're done with your interaction and your consultation with the doctor and medicine and lab. You go back to the car and you get into the car to return home. My question to you is, Are you satisfied with your visit? Count the number of yes, count the number of no from the things that you have listed down. You'll get an idea. How satisfied are you with your visit? So you may write your satisfaction score and dissatisfaction score in the chat box. Out of all the questions, you can write your so 3 yes and 4 no's for Mr. Mohan. Dr. Puneet says 60% yes and 40% not. Dr. Seema also says 60% satisfied. Dr. Peen says satisfied 5 and dissatisfied 2. Okay. Dr. Hamid Azad says not satisfied. Score is 50 out of 50. So that 50 out of 100, that means 50-50. Absolutely. Dr. Himanshu also says 60% satisfied, 40% dissatisfied. Again, Shipra also says 50% satisfied. Mr. Mohan is more precise, 65 and 35. Oh my goodness, Shahrukh says all not satisfied from a government setup. I completely empathize and agree with you, Shahrukh. Mehdi says that considering all the expectations, 70%. Okay, so you think 70% were okay. Dr. Praveen says 60% and Mr. Vijay says 7. No. And 3 yes. That means only 30% satisfied. Halal says 60% or 50%, 20%. That means this is your own scoreboard for your own setup. If you were a patient and if you are not satisfied with your services, in spite of the fact that you know your setup and you would actually overrate it, you would rather not even go for smaller things that actually don't matter much. Even then, no, expectation is not preset, Dr. Himanshu. Expectation is that whatever expectations you had from your setup, if you were a patient and you went to the OPD as a patient, the place where you park your car, place where you first interacted with the receptionist, then the waiting area, then the doctor with whom you had your consultation, and then these are the primary areas, where you will have almost 80% of the visitors coming. Patients going to the indoor are much less, but most of the interaction or consultation happens in the OPD. So that's the major area of your hospital. And see, most of you said 60%, 50%, somebody said even 30%. So if according to you, you think your expectations are not met, something like 80, 90 or 100%, if patients say that we are not satisfied, how do I call their expectations as unrealistic expectations? If these are your expectations, so are your patients' expectations. And if you're paying for this service, I think except Shahrukh's hospital, that is a government setup, all of you are from private setup. Patients are paying, and they're paying hugely. A lot of time I send my patients for psychiatric consultation wherever I think, okay, this patient has acute depression or something where there's a need for medical intervention, and I have tie up with a couple of psychiatrists. They come back and they tell me that I was charged quite heavy, 3,000, 4,000, 2,000 as consultation. But the doctor just gave me 10 minutes, 5 minutes. I was not even able to, tell what I wanted. Absolutely, I agree with Dr. Puneet Gupta, who says 100% satisfaction is not possible in healthcare at the cost we are charging. Absolutely. I completely agree with you, Dr. Gupta. For any setup to be successful, there are just 3 things that you have to primarily focus on. And if that can be taken as a takeaway from today's session, I think my job of holding today's topic is done. They are A, B, and C. Can somebody guess what is A? A, B, and C. Very simple. Can somebody guess A?
Attitude.
Okay, good guess, but actually not, but then it's okay. It's okay. I'm glad that you answered. Okay, what else?
Availability.
Okay, again, a good guess. Not exactly what I was looking for, but then good attempt.
Accuracy.
Accuracy. Okay, again, a good guess. Good guess. So A is, Dr. Azad, you're right. Ambience of your setup. Please remember, people, when they meet you for the first time, they don't know who you are, how qualified you are, how good you are at your clinical skills. But people normally look at the ambience and they okay, it's a good hospital, or it's a good clinic, or it's a good setup. So first is ambience. So even if you don't go for any extraordinary ambience, I remember on LinkedIn, somebody had posted, a very beautiful OPD picture of a very huge hospital in Hyderabad they had recently constructed. So somebody had actually that post was trolled by people. They made a mockery of that. I mean, if you make such huge, big hospitals like hotels, ultimately you are going to charge your patients to pay for it. And why should we expect the patients to pay for something that can be done at a smaller budget? So I'm not in favor of, encouraging you to have a huge setup or a big setup, but then at least a neat, clean, safe, ventilated, presentable setup I'm talking about. So first is ambience. What is B? What is B?
Behavior.
Behavior. Excellent. Good guess. Behavior. Dr. Himanshu also says behavior. And what is C?
Care.
Clinical acumen, clinical skills. So if you look at these three things, if your ambience is okay, if your behavior is okay, your clinical skills are in place, excellent. Excellent. Now let us look at the combination. If your ambience is excellent, all 100%, but the behavior of the staff is not good, and even the clinical acumen of the staff is not okay, your patients are not going to be happy. Because the food may appear very tasty, but the moment you eat it, if it is raw, or it's smelling, or it is stale, nobody's going to take it. On the other side, even with average clinical skills, I'm repeating, and it's not me who is saying it, is studies that say, even with average clinical skills and average ambience of your setup, if your and your staff's behavior is good, your patients are bound to come back to you. When you go to eat dosa to a place, Dr. Puneet, I know you're not agreeing with me completely, but what I'm trying to say here, I've seen people, doing excellent practice. I mean, this I've received even as, feedback from the doctors that, I have a friend who is not clinically extraordinary, but he is doing an excellent practice just because he's able to develop wonderful rapport with the patient. And also he has fine-tuned his staff in such a manner that the patient should feel being cared, looked after, and welcomed. So of course, if you have excellent skill, there's nothing wrong in it. And especially for super specialized disciplines, you definitely require excellent skills. I'm talking about in general. But what is observed, patients value more of your communication and your behavior. And even the answers that you have given to the questionnaire, that again indicate to the same thing. But I'm going to give that questionnaire once again, because there has been some confusion. Some of you have probably rated 8 as the highest or the most important expectation to you. So we will just do it quickly. It's just a matter of 2-3 minutes, but we'll do it in a minute. So what I'm trying to say, Yes, Dr. Puneet, go ahead.
Actually, I couldn't understand how to answer that because
I know.
yeah.
That questionnaire I have designed so many times, but every time I, give that questionnaire to answer, the answers I get, even I'm not satisfied. So I'm actually every time revising and trying to see how can I get what I'm looking for. So what I'm looking for is what most of you value the most. Actually, these are 8 expectations that has come out after a study of 40 expectations that you offered to your patients to choose from. And these 8 were the topmost by the patients. So I gave it to all of you thinking that, what do you think? Do you also rate in the same manner, or it's something that is different from that? And most of you, I'll show you what is, what has come as a result. One is restoration of health. Everybody looks for that. So that's your clinical acumen. And second is your kindness and communication. And third is your team building. The team, teamwork between the, different disciplines or different specialists or different healthcare providers. So these 3 things patients mainly look for. That's the thing that they are looking for. So now coming back to the question, this activity that I gave you, I'm going to use this towards the end when I'm going to introduce you to a very beautiful concept called design thinking. Have you heard of design thinking as a concept? Anybody? Nobody. Mr. Mohan, you were nodding yes, Mr. Vanshi Mohan, and I think also Mr. Vijay Kumar is, because they are from training fraternity, so maybe no. Mr. Vijay Kumar, you know about what is design thinking?
Yes, yes. I mean, I heard about it, yes.
Okay, and have you done any training in this?
I have taken, I have participated in one of the training about how to design the products and all those things using the design thinking. Yeah.
Wonderful. Thank you. But we will discuss this at length towards the end, where I will introduce you to a concept of design thinking, which is actually being extensively used across the world. We are still learning, but once you will get to understand it, you will find it extremely useful. There are programs available. There are online programs available offered by Harvard, Stanford, and many other organizations. Somebody was telling me even IIM is also planning to offer a design thinking program online. And if you get a chance to do that program, I would say each one of us must do it, because that's going to be a huge change, bringing change in your, perspective about your, patient care. So this was just to give you a feel of what exactly, happens when somebody comes to our setup and how they evaluate our services, and then they go back with some impression, were they satisfied, were they happy or not happy. But if your behavior, if your staff behavior is okay, I think ultimately they forget about what was not available. But if they're paid for the services are not good, behavior is also not good, they're going to go back very, very dissatisfied. Very, very dissatisfied. So give me a second to share. Okay, did you all get a chance to read that case study on page number 33? I had written in the group. Only some could. So raise your hand, those who have done it. Okay, Dr. Monga says he's done it. Thank you. Who all has read it? Okay, thank you. Dr. Azad has done, Mr. Vijay has done, Lal has done, not all of you have done. Okay, Mehdi has also done, very good. But I think Dr. Seema hasn't done because I could see an element of surprise on her face. Which study? Okay, so we will actually, there are 4 or 5 studies in the background material that I have sent you. From page number 33 to I think 40, there are 3 or 4 studies. You could even design your own case study to discuss with your team when you want to help them see the patient's perspective. So this activity that we are going to do is just to give you an idea. We do things, perfectly well from our perspective, but then why isn't patient satisfied? So it's more like, observing the whole case study from that lens. So let me show you the case study in case if you haven't read it. We can quickly read through. Can I request anybody to read the case study for everyone? Just one second, let me. Where is here it is. So this is case study 1. Who would take the responsibility of reading? Shahrukh, will you do?
Yes, ma'am.
Okay, please go ahead so that everybody can. And in case if you get tired, then you tell me and I'll request somebody else to read it for you. Yeah, please go ahead.
Okay, ma'am. So the case study 1 is ready, set, go. Right after dinner, Abdul Rahman clutched his chest and told his wife Zeenat that he has thought he had a heart attack. Zeenat wasted no time getting Abdul and their 16-year-old daughter Katrina into the care and raced into to a nearby hospital. Although the ER was quite busy, Abdul was placed into a room immediately and attended by Dr. Raghavan and the nurses on duty. After taking the history, the team checked his vital signs, including pulse rate, blood pressure, breathing rate, temperature, and auscultation. All preliminary tests were normal, and Abdul noted that his chest pain had also diminished. "I'll be back in a while," Dr. Raghavan said. The nurses also left the room, going outside to take orders from Dr. Raghavan. Zeenat held Abdul's hand while he was still lying on the examination table. Katrina began to cry. "Dad, this is scaring me so much. I don't know what I would do if anything happened to you." "I'll be fine," Abdul replied. "I am feeling much better already. I bet they'll let us go home very soon." 2 or 3 times during the next hour, one of the nurses looked into the room, scanned various instruments, and left. Another hour passed, then another. I think they forgot I think they forgot you were here," Zeenat said. "They know you're fine, or the doctor would be checking on you. I'll find someone and see if they are finished."
I think somebody's device is on. If I may request you to mute your device. Give me 1 second. I'm muting it. Yeah. Yes, please.
I'm starting from the new paragraph.
Yeah.
I think they forgot you were here," Zeenat said. "They know you are fine, or the doctor would be checking on you. I'll find someone and see if they are finished with you now. I'm getting impatient, just sitting here and with nothing being done and no one telling us what's going on." Zeenat went to the large circular desk in the middle of the room and asked her nurse if it was all right for Abdul to leave, since they had been in the room most of the time alone for quite some time. "I will ask Dr. Raghavan," a nurse said. "It may be a few minutes. He is with another patient. We might as well leave. He is feeling better and there doesn't seem to be a reason to sit around here," said Zeenat. When the nurse saw Dr. Raghavan, she asked him, "Dr. Rahman's wife just said that they want to go as nothing is being done, so he must be fine. She thinks that they should leave." "That is ridiculous," said Dr. Raghavan, almost shouting. "So she is bored and wants to go home? Tell that female that this isn't about her and her comfort. It is about the patient. Tell her no. I am not releasing the patient until we have completed our monitoring and we are certain that he is not at risk." Katrina had wandered outside of the exam room moments earlier and couldn't help but hear this entire conversation through the conference room door. She went back to the room and said, "Mom, it sounds like the doctor is pretty mad at you." "You are kidding," Zeenat said. "What for?" "He thinks you want Dad to go home just because you are tired of sitting here and that you don't seem to care whether Dad is well or not. He told the nurse that he told the nurse that they were still monitoring him." "They are still monitoring him? How did I know? No one has spoken to us for hours. They just left us in that little room. I think I'll have a word with the doctor." Just as she spoke, Dr. Raghavan entered the room.
Thank you.
Discuss-
Thank you,
Okay.
Shahrukh. Yeah. So quickly moving on to the discussion points. By the way, should the Rahman family have known that Abdul was being continued to be monitored? Yes or no?
Yes.
Absolutely. But how would have they known?
They have to be informed by the treating team, maybe by the staff nurse or the doctor himself. Unless we explain the patient and the accompanying relative, it's bound to happen that they will find that if my patient is responding well or recouping well, they will always think that the primary treatment is over and why to wait now. And emergency room is a place where nobody would like to stay for no reason.
Absolutely.
So that reasoning has to be properly explained to the patient. And once we are explaining, even if we have evaluated, the explanation that why we are keeping you in monitoring is also a valid part of understanding between patient and accompanying relative.
Absolutely. So that means there should have been some explanation coming from the doctor and then the nurses, which did not happen. I'm sure this you must be seeing a lot of time happening right in your knowledge. And that becomes a real, source of dissatisfaction for patients when they feel that they have not been informed what is the situation. By the way, if I may ask you, why don't we inform them properly? Why don't we share the information?
Because
properly?
of the lesser time. Doctors and staff may be busy in other emergency patients.
I would agree partly and disagree partly to your statement.
Sometimes patients
Yes.
don't understand the stress and anxiety of the doctors also.
I completely understand. Sometimes even we do not know what is the right diagnosis. Even we are waiting to make the right that also could be a reason. Dr. Praveen says we take for granted at times that, okay, we don't have to explain and the patient would automatically bear. Then, of course, patient's anxiety, and very rightly said by Dr. Puneet, even doctor's anxiety, because we are sometimes not even sure what exactly it is and now what to see. But the thing is, when they have come to the hospital, besides being attended promptly for the problem, after the patient has settled down or has attended, they expect some communication coming from us. So it could be as simple as this, that we are still investigating and we are not sure what it is, but we are observing your patient. But good that you brought the patient and we are, attending to your patient. So it doesn't have to be, okay, this is what is the diagnosis and this is what we're going to do. For example, in this case, a simple explanation like we need to observe him. Although his ECG is fine, but we still need to observe him. I don't think that would have taken much time. So Dr. Monga says, not in priority among other things. I think that's also one of the reasons, because we don't think it is important to inform the family. We look after the patient, but we don't, consider it essential to speak to the family. Shahrukh says most of the times, sorry, there is a missing word, Shahrukh, if you could see what exactly you have written. Less sick patients, yes. Because I'm busy with sick ones. I make the less sick patients wait because I'm busy with this sick ones. I agree, but then the patient who is less sick is sick from their point of view. So if you go with stomach ache or toothache, for the clinician, it may be a small thing, it's nothing. But for you, toothache or your stomach ache is something that you have been suffering for hours. And you want a relief for that. So we really got to understand there can be delay in the communication, or there can be a substitute for the communication. And few words of assurance that, okay, as of now, this is what we see. It won't take much time. And if you remember in the first session, I did make a mention when we do doctor-centered communication, we spend around 7 minutes and 45 seconds per consultation. And when we do patient-centered communication, we spend just 45 seconds more. But the patient satisfaction gets multiplied many, many times. Okay, Mehdi says, I think we don't think it is necessary to brief. Yes, I think that's one of the reasons where we think, because we are coming from an era where it was a doctor-centered practice, where patients just had to listen and they were okay with it. So one of my questions you will see in the presentation is, are these expectations unrealistic or they are new? I would not call these expectations unrealistic. But yes, they are new because we were not used to it. Dr. Seema says lack of empathy. Yes, there are times when we don't empathize with the patient and the family. And then we kind of don't realize why we need to address their concern. Mr. Mohan says, since it's a daily routine for them, they assume that patient would have understood by whatever they have communicated. Again, communication gap, we assume that, and studies have shown that in 50% of the cases, we do not explain them about their condition or whatever their diagnosis is. Are we really respecting patients' right? Non-compliance from multiple aspects. I think wonderful. You are now, starting to look at things from the patient's point of view. So these simple communication where you examine the patient and share a set of information. For example, once you have done their physical examination, forget about the emergency. Of course, this is an emergency setup. Even if you have done a simple examination of eye or ear, or maybe chest examination, you can look at their face and they'll have a question on their face. What is it? I don't expect you to know the exact answer, but if you can just say few words saying, apparently it looks like this, but we need to investigate further. Or maybe it looks fine, but I would still advise you to go for ultrasound and let's confirm or rule out. So even that word of explanation is good enough, and they'll say, okay, ठीक है, ultrasound करा के फिर देख लेते हैं. ऐसा है, सब ठीक लग रहा है, ये टेस्ट करवा के देखते हैं आगे क्या निकलता है. So they get to know we are part of the interaction. But when you take them as completely mute spectator to what we are doing, I mean, earlier it was okay, but now they are not happy with this. You will also see that their expectations also change. So if you look at the third question, how did the expectations of the Rahman family change during their visit of the emergency room? So if I may ask you, what were the first expectations when the patient was brought to the emergency? You may write in the chat box. What do you think were the expectations?
The patient should be seen immediately, and he should get the attention of the medical team as early as possible. That
Absolutely.
was, yeah,
absolutely.
They have provided that thing immediately. There is no lack in that service.
Absolutely.
Yeah,
absolutely. So when you do everything, see, we have done our job. We thought patient is my primary, client, so I'm supposed to look after the patient, but family is also my client. So if I say, allow me to settle the patient, once I've settled, I'll come back to you and speak to you and make them wait, they'll be happy. When you do everything for the patient and don't involve the family or don't inform them, so it is something like winking at a girl in dark. She does not know.
And we have to take care more of patient attendance rather than patient.
Both.
Because patient will be lying, he may not be knowing anything. Absolutely. And attendance kind of will be like little concerned.
Absolutely. I completely agree. So that means, of course, the primary expectation is please look after me, please attend me, please relieve my symptoms, relieve my suffering. That's there. But you will see there will be change in their expectations. So we can't be unhappy about it. How can you have this expectation from me? So Mr. NC Mohan, I like one of the answers that you have given in the chat box. We underestimate the patient's capacity to understand. I completely agree with you. A lot of time we think that they will not understand, and therefore we don't care to explain them. You may not explain them everything, but then giving an overview, giving them an idea, giving them some answer will help them calm down and be with you, comply with you, listen to you. Absolutely. So yes, Dr. Seema, I agree that they expect immediate attention when they come to the hospital. The clinical concern is, yes, Dr. Monga, that I should be attended at the earliest and should be relieved of my, symptoms. But at the same time, these expectations are going to be changing after every now and then. So my question is it abnormal to change these expectations? Actually, no. That's so very normal. It's going to change, and let's be ready for it. Let's be prepared for it, because that's what is going to every time happen, and you better be prepared for it. And even tell your staff, then don't be unhappy when they have these expectations from us. And then my last question to you is, by the way, what behaviors of the physician and nurses affect the patient and the family? If you would write in the chat box, what behavior you think were inappropriate, which really affected the family, patient and the family? Arrogance, absolutely. Arrogance, clearly visible. Antipathy, very good. I think I completely agree with both of you. What else? Not communication, absolutely. Did not update the family and the patient about what is their understanding of the condition. Non-hearing anything, again, same thing. Lack of communication, absolutely. 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 Attitude, their indifferent attitude. Yes, I agree with you, Dr. Seema. Improper language, absolutely. Non-comforting attitude, absolutely. That's very, very true. I completely agree with you. Shouting of doctor, yes. Two things that I was looking at, of course, a lot of you have written anxiety, and then doctor's perception of relatives, and then not explaining the facts properly. Less concern for patients' expectations, poor para language, absolutely. Very good. I think, Dr. Ajad, this is what I was saying. Two things that actually were actually out of context. One was the change in the version the nurse made in the communication when she spoke about the wife's statement to the doctor. She said, she thinks we are not doing anything. So it completely changed the version or changed the statement given by the patients. And a lot of time we do this, we actually add our own anger, our own understanding, our own interpretation to the message that actually complicates the situation. And then the second behavior was coming from the doctor, who became angry and aggressive, and he shouted, and the language that he used was not respectable for the patient's attendant. So that means these are a couple of things we unknowingly do, and we are not mindful. And that's something we really need to keep in mind when we are communicating with them. Yes, Dr. Richa, indirect communication can change the version completely, and also create more confusion. Yes, Dr. Venkatesh, I agree with you. Insensitivity, apathy, I mean, that was visible she went 3-4 times in the room. The nurse went 3-4 times in the room to check the monitor. Even the non-verbal communication, maybe in terms of, a smile or asking, how are you? Is there anything that I can do? Are you comfortable? Do you have any question? Could have actually resolved this communication gap. But a lot of time when we don't care to communicate, see, we lack proactive communication because we consider communication as a burden. Those of us who are happy to communicate, they will find time. They will not have difficulty communicating. It's not about time, it's not about burden. So a lot of time I get to hear, especially from the government sector doctor, you have no idea the number of patients we are seeing, and we don't get time to, communicate. You don't require time to communicate. Communication is not needing time, it is intention to communicate. And 93% of the communication is non-verbal. Your patient comes into your visual field. The moment you lift your head, make eye contact, smile, and ask them, show them a place to sit, that's enough to build rapport, initial rapport. How much time will this take? Not more than 4 to 5 seconds. But a lot of time, we don't lift head, we don't make eye contact, we don't smile, we don't show them where to sit. So the patient is confused, am I really wanted? Am I really, I'm in the right place? Is the doctor really wanting to talk to me? Does he have time? Does he respect me? Do I exist in his visual field? And these are all small things. They don't require additional time or effort, but that's matter of our intention to connect with the patient. So if I may share, what do studies say when it comes to patient expectation, you'll be actually surprised to see some of the results. So this is one of the recent study that I came across. Actually, I attended the whole program of this study, and I was fortunate to attend the different understandings that this survey brought in. So this study was done in 2019. 45% of the families reported that they were not empowered in the treatment of the patient. They were feeling unempowered. Also, they expressed inadequate clarity on diagnosis, treatment, and the procedures or the things. They also reported rushed consultation. They felt that they were not given enough time to talk about it. So I remember in one of the programs, one doctor shared his experience with me. He said, I took my father-in-law to one of the very famous cardiologists of Delhi. He said, as it is, the getting appointment was not easy, but I got it through some contact. I could get a appointment. I went for the consultation with my father-in-law, and I had the bag of all his documents with me because he was seen by so many other doctors. So he said, this cardiologist, he examined my father and he father-in-law, and he wrote a set of investigation. During interaction, during consultation, he did not make any effort to connect with this doctor who is also a doctor. But he just spoke to the patient, and all that also absolutely to the point. If the patient tried, talking about what the other doctors have said, he said, I have nothing to do with that. Let me examine you and do your, what tests you require, get them done. He said, I got my test done. Then again, I took another appointment. Again, I went with my father-in-law, and he was seen by him. And then he just saw the reports, and then he wrote the treatment. So some of you may think, okay, it's fine because he's done his job in an excellent manner. But then connecting with the patient and the family is equally important. And we have talked about it at length in the beginning, that it's important to build rapport, not just for, making them comfortable, but also to get all the information and give them satisfaction that they have been heard. A lot of patients actually, report that it was a rushed consultation. And then they perceived lack of involvement in deciding the treatment and the options available for the treatment. So this is a recent study, and almost like 45-50% of the families have reported this. So that gives us a fair idea about how much do we really care to involve and engage the family in the patient's treatment or decision about the treatment. According to the same survey, 35% of the patients indicated that they were not allowed to describe their condition or symptoms. That means the time given to talk about their problem is probably not enough to create satisfaction that my problem has been explained well by me and has been heard by my doctor. So that also shows the importance of letting your patient speak. Especially, we all know when the patient is able to talk about the problem, it also ventilates the emotional burden. Patient also gets clarity about what their condition is like. According to the same survey, 32% of the patients indicated that doctor did not straightforwardly address their questions and doubts. Again, when it comes to, answering their questions, addressing their concerns, or whatever issues they have, whatever questions they have, if you don't satisfy them, especially in today's era where patients are window shopping, they'll come to you, and ultimately they will go to the doctor who can actually, listen to them and talk to them and explain them. I remember I sent a cousin of mine to a friend of mine who's a gynecologist, and this lady had to undergo hysterosalpingography. So she went with her husband to this gynecologist, and they asked a lot of questions. to the extent that in the end, the husband apologized by saying, I'm really sorry I'm asking you a lot of questions, but I had actually a lot of concerns, so I needed to clarify them. And this gynec friend of mine, very politely, she said, it's perfectly all right. It's my duty to answer your questions. You're paying me for the consultation. I really do not know how many of us really handle situations like this in such a manner. And then this couple got the procedure done there, and and it's not just one patient, chain of patients, because they were satisfied. So any patient having any gynae problem, they would refer them to this doctor. She's a wonderful doctor. Talk to her. She'll listen to you. She'll explain you well. So all this actually helps us in getting more footfall to our setup. 75% of our patient footfall comes from the word of mouth that our patients spread about us. That's the importance and relevance of, but you can see a lot of patients go dissatisfied because their questions and their doubts have not been clarified. Now, I think we need to ask, are these expectations unrealistic or new? They are new because we are not used to. That is why we find uncomfortable to deal with those expectations, but they are not unrealistic. You did the first process mapping yourself. You visited your own OPD and you had some expectations. Were those expectations unrealistic? No. Were they met? Just 60%. So honestly, these expectations are not unrealistic, but they are new. So therefore, we are kind of finding it difficult to start with to satisfy these expectations. So if I may explain you a model of patient's expectation, that will give you an idea how we can move on step by step from basic to the delighters. So if I talk about the first level of expectations that your patients have from you, and they are called basic expectations. So basic expectations are the one, they are unspoken expectations. They're expected to be satisfied. If they are met, client is not going to come and say you thank you for fulfilling my expectation. But when these basic expectations are not met, they are going to be dissatisfied. So can you give me examples of the basic expectations that the patient has from us, which has to be satisfied, which should be satisfied? Please write in the chat box. Okay, proper care, waiting area, to listen to them, respond to the questions, explain them well, properly. Absolutely, absolutely, to listen to them. And these are all basic expectations. Now you need to check how many of us are really even fulfilling these basic needs. So if a patient is, admitted to a hospital, a room or a bed, a clean sheet, availability of toilet, a well-ventilated room, neat and clean environment, protection from infection, they're all basic expectations. So if they are there, they're not going to say, oh, this room is ventilated, or this room is clean, or this toilet is clean, but they'll be happy that these things are there. So even in terms of communication, like you are mentioning, proper briefing, less movement, active listening, answering, disclosure of provisional diagnosis, channel to reconnect, keeping them posted about the doctor's availability and time he would be seen. Absolutely. So these all come under basic expectations that the patient will have. Are we fulfilling them? You can check it for your setup. The second set of expectations are called satisfier or performers. Even if you are able to look after these needs, most of your patients are going to go back satisfied. So these expectations are, when they are met, the client is satisfied and happy. When they are not met, the client is going to be dissatisfied. And that is where they can actually, create ruckus and be unhappy. So can you give some examples that you think are actually the performer or the satisfier, expectations that the patient would have from us? Write in the chat box, please. prompt reply, engagement in decision making, proper explanation, absolutely. When they're told about patient care, okay. What else? Good outcome, patient outcome. That's a very provisional diagnosis, clarity on provisional diagnosis. Yes, if there's a confusion, absolutely. Courteous behavior, they're going to go back happy and satisfied, absolutely. So that means some of the things, if we can integrate in our basic setup, automatically that's going to create a lot of satisfaction. Timely update, absolutely, absolutely. There's another, yeah, there was one more answer into, let me check. Okay, having smile on the face of the clinician. Okay, patient's expectations are met. Yes, I think these really go a long way in satisfying your patient. Smile plays a very big role. The moment you smile, actually the whole environment becomes light. People feel connected and wanted and respected. The third level need, which is now being exploited by a lot of corporate hospitals, is called delighters. So delighters are the expectations or needs. These are the requirements the patient may have, but they don't expect to fulfill. But when they are fulfilled, it actually becomes a delight. So sometimes when the unexpected requirements are turned into pleasant surprise, they are called delighter. So can you think of some of the services now the corporate hospitals are providing or your setup is providing that is considered as a delight? Patients go really gaga. I didn't expect that you will be doing this for me. Birthday celebration, yes, I see this very often. Flowers, yes, I agree. Again, this is a new trend now we are starting. Get well soon card and flowers. Discounts, yes. Free refreshments, absolutely. So these are also taken as, they go as a delight. Follow-up email or call, yes. Follow-up email or call. Celebrations, birthday or marriage anniversary or something very special, absolutely. Some are providing gold coin. This is something new, Dr. Puneet. What is this? So how much are they charging? Okay.
Yeah, they are giving lotteries. Yeah, these kind of practices are also going on.
It's a new information to me because I have not heard of something like this. I know we are playing all sorts of gimmicks to lure the patient. Of course, as long as they are within the limit of ethics, it's fine. But then, yes, decoration for the newborn. Yes, Dr. Moga, I agree with you. Recently, as I shared with you that my daughter delivered a baby boy in the month of February, and that's the reason why I am in US. So as a delighter, they offer a photo shoot for the baby and very much in the room. So they will fix an appointment. A photographer will come with all the paraphernalia, with the basket, with toys and all that, and they'll take a picture. Of course, that's actually again I wouldn't say a bait, but that's a way they engage you. They tell you, okay, if you want all the photographs, you have to pay $200. And every parent is more than happy to shell those $200 because they want all the pictures of their child. So they'll give you, but then it's something that they are, experimenting with. So there's nothing wrong in, delighters. Only thing is it should cost a lot to the patient because ultimately what you're going to do is going to be paid by the patient. So we got to remember that if we are adding too many gimmicks in our system, then sometimes people make a mockery of it and they don't really appreciate. But yes, there are a lot of ways. I mean, a simple delighter for me will be if I have an appointment with my doctor and if he's not there in the clinic, I receive a phone call one day in advance. Ma'am, your appointment is cancelled for tomorrow as Dr. So-and-so is not there. So just to save your time, I'm reminding. Or a delighter could be, I've got my blood test done and I get the report on my email. I don't have to go back and follow up and check for the report. I get it directly. So I think we have to be more innovative in, finding delighters, which should actually add value to the patient care and should come as a pleasant surprise. But yes, definitely these are being now more and more, used in the patient satisfaction. So if I go by the data, some of the essential elements of patient satisfaction. And if you can, incorporate these things in your setup, you are bound to do extremely, extremely well. Number one is communication with the nurses. So it's not just with the doctor, because a lot of time patients know doctor will not communicate with me enough. So is there anybody else who can fill in the gap? So it could be a nurse, it could be a care coordinator, it could be your optometrist, it could be your, assistant, but somebody who can fill in the gap. Second is their communication with the doctors. Third is communication and clarification about medicines. Fourth is responsiveness of the hospital staff. They may have a request, they may have a complaint, they may want to know something. How promptly do we respond to that? If there's a call from a patient, the doctor is not in the clinic. If I say, I'm sorry, he's not there, but give me a little time, I'll connect you with him, and in 5 minutes I get the return call done, they're more than happy. Fifth is pain management. Sixth is cleanliness and quietness of the hospital setup. Seventh is discharge instruction, and 8 is overall rating of the hospital. If you can look after these things, most of your patients are going to be very satisfied and happy with the way you are doing. I can see some comments. If core services are very good, delighter activities may prove good. Absolutely, because then they know that you are not doing it just to fake, but that's the way, that's the culture you have created. That's the culture you have created. Absolutely. But do you think these things should be promoted to healthcare? Dr. Puneet, I think I've answered your question that as long as it is within the parameters of, ethics, it's all right. And if they're adding value to the patient care, and they are not like adding unnecessary cost, it's perfectly all right to provide this, because what we consider as delighter is probably a norm in the Western culture, in the Western setup. And we are trying to improve, and that's how things improve. So at this juncture, I wish to introduce you to the concept of design thinking. And it's a very interesting concept, and I would really, really want all of you to start working on it, learning from it, and using it for your setup. Now, what is this design thinking? Design thinking is a concept where you actually look at the things from your client's point of view. So if you will look at Amazon, Uber, VFast, Oyo, Zomato, and even IHC, they are all working on the concept of design thinking. Now, what is design thinking? Let me explain to you. Design thinking is, you can see, one second. Okay. So design thinking has actually 5 clear-cut phases. The first one is empathize. The process mapping I made you do, imaginary process mapping that I made you do, was to help you empathize. The second step is define. I'll explain you briefly about all 5 steps. Second step is define. Third is ideate. Fourth is prototype, and fifth is test. So let me explain each one of them clearly. So when we say empathize, it's actually done to develop a deep understanding of the challenges your clients are facing. So to understand what your patients, go through when they try to reach you, or when they come to your clinic, or when they try to avail your services, and then go back and they come for follow. If you are able to, develop a deep understanding, definitely you will know where the loopholes are, where you need to correct. Then the second step in design thinking is clearly articulate the problem you want to solve. So the OPD services that we just now visited in the first, beginning of this session as a process mapping or imaginary visit, was to identify different areas. So you have now the list of areas wherever the problem lies. It could be in the waiting time. It could be waiting area. It could be the basic amenities in the OPD. It could be the behavior of my lab technician or the pharmacist, or explanation given by the pharmacist. You have now identified the areas that are the source of dissatisfaction. Then the third step is ideate. So ideate is when you are brainstorming and creating multiple ideas, which could be potential solutions to the problem. So you don't resolve the problem as a knee-jerk reaction. Okay, there's no ventilation, have a window here. Okay, now we have ventilation. No. So as a team, you work together and you find out what are the possible solutions. And usually brainstorming is a wonderful way to do this activity. I think one of you will be talking about brainstorming as a pedagogy. You will get more understanding of brainstorming as a tool here. So ideate is basically to create ideas which could have potential solutions to the problem. And then you develop a prototype. So prototype is on the basis of the ideas that you create, you prepare a kind of a draft, what you think will work. Maybe that can resolve the problem. So you design a prototype that is a series of, tests or part of the solution, you bring them together. And then based on that prototype, you do a testing. So for example, you want to reduce the waiting time in your OPD, or you want to upgrade the appointment system in your OPD. So you come up with ideas, you try, and you through discussion, you identify 1, 2, or 3 ideas that you think will definitely work. And then you try implementing them for a period of time and see how that works. Of course, there will be, some lacunae remaining, which we need to correct. And once that's done, then probably you will apply it extensively in all your, healthcare facility. So this is a concept which is being extensively used in healthcare now. So a lot of time when you go to, for some diagnostic services, you would see such colorful, MRI stations, where for pediatric cases, they feel that children and parents are very anxious when they come for investigation, to earn their cooperation, to make them comfortable, to make them feel, to get them acclimatized to the environment. This is how now they are designing the MRI section or the CT scan section. I remember I went to, I don't know how many of you have visited, Chacha Nehru Bal Chikitsalaya Hospital in East Delhi, if anyone of you is in East Delhi. So if you will go there, you will get to see some of the wards have been actually painted with cartoon characters, because they know their main clientele is pediatric. So to make those patients, kids become comfortable and, and also calm them down, they are using these techniques. This is the OPD of one of the hospitals. I'm not naming the hospital. If it is visible, it's okay. But otherwise, this is the OPD, not a waiting area. So some of you may wonder why the hell we need all this. But then that's your choice. That's what is your level of functioning that would, automatically guide you how do you want to design the waiting area. But then, of course, having a waiting area which is comfortable, which is, well ventilated, clean, it's definitely going to send your patient satisfied. Another, waiting area of, I think it's written Apollo Cradle. So you can see again, these are all designed on the concept of design thinking. These are all designed on the concept of design thinking. So I think it's time that we understand patients' expectations and meet them midway. Try applying the concept of design thinking to your visit to the hospital OPD. I think that's what we have done just now. So what I would say, now you have already learned about the, audience for whom you're designing. If you were a patient, what challenges you will experience or your patients will experience. Define the problem. So this is kind of a homework for you, which you can consider. Define the problem, create a point of view that is based on user needs and insights. So what my client needs, what are their needs? So you can define, based on that, you can create ideas, and never do it alone. Always have people who can give you new perspective. It's good to have people who are not even from healthcare, because a lot of ideas can be actually transposed from one discipline to another. People from corporate sector or from different industries can be, used to ideate, because they may be already familiar with this kind of a setup, or they will be able to give you new input. So based on those ideas, now you need to actually create a prototype or maybe a small sample. You can see a small that will help you to give you a rough draft that you can test. And if that test is okay, if you think that's helping to save patients time, to increase patient satisfaction, to decrease patients waiting time, whatever your objective is, that means this is working, and then you can apply it for for yourself. So I would suggest, although this was not part of the patient expectation part, but then I thought all of you are in the management position. So I just don't want to send you back with the idea, okay, these are the expectations. How do I study my patient's expectation, and how do I really meet those expectations? This is an excellent tool. This is an excellent tool that will help you in making your patient's expectation. So this is in a nutshell about understanding patient's expectations. Any questions about this? Something new for a lot of us? I agree. I completely agree. But then there's a lot to learn from these, concepts. And don't think that these are only suitable for big corporate setup. Even in your own individual practice, you can work. You can use these tools and improve your services. And you could take one step at a time. I'm not asking you to change everything as per NABH or JCI's, requirement. One step at a time, I think you'll find it extremely useful. Yes, Mr. Vijay, I completely agree with you. It's a very powerful tool. And it is being extensively used across the world in various industries. So Zomato, Uber, all Oyo rooms, Airbnb, they're all actually, the services are designed keeping in mind the client. How many of you do online shopping? Almost most of us. I mean, the provision of, getting things at home, and if you don't like returning it without any pain, that itself is such a delight. It's a delight. If I talk in terms of delighters, it's a delight. If I buy a product from market, and if I go back to the shopkeeper and say, sorry, I don't need it, can you get your money back? Did you get your money back from the shopkeeper?
No.
I have never experienced that pleasure. They'll say, ma'am, le gaye, kaam khatam. I don't know. Dr. Himanshu says that, yes, if we see what other industries are doing for customer satisfaction, we can look what we can pick from that. Absolutely. I'm not saying to completely ape them or copy them. No, but we can learn from them. We think creating patient delight is something like I am being undervalued and patient becomes the primary. Very honestly, that's the reality. Very honestly, that's the reality. As long as the patient was not paying, you could, play the way you wanted. When somebody pays, they want value for money, value for their time. So I can be unhappy, but I can't change the situation. The choice is yours, whether you be unhappy and crib about it, or you change your, perspective and start working on it. Okay, this is what my patients want. See how I can, what all can I do? How can I change my setup? How can I make things better? Dr. Praveen says, not only meeting the patient's expectation, but also giving them perception of fulfillment of their expectation. Absolutely. That's the actually ultimate now, what is quality? What is the definition of quality? Simplest definition of quality. Simplest.
Continuous improvement.
Okay, wonderful. Absolutely. So that means I'm not asking you to completely change everything. I'm not a one step at a time, one step, baby step. And if you go by that book by, what is his name? James Clear, Atomic Habits. Has anybody read Atomic Habits? Mr. Vijay has read it. Please read Atomic Habits. This book says if you make just 1% change every day, 1%, just 1%, which is negligible, by the end of the year, there will be 37% improvement in your functioning. A drop may not appear anything to look at, but the cumulative effect that will have at the end of the year will be very huge. It's a beautiful book. I think I have soft copy of it. If you're interested to read, I'll share with the group. I'll definitely share. I'll share it right away. So it's a beautiful book. I mean, I was impressed with some of the concepts that a writer has given. He said, if you are starting your flight, say from Bangalore to Delhi, of course, he has given an example of the US, but I'm giving you an example of India. If you're starting your flight from Bangalore to Delhi, and if the pilot changes just 1 degree of the direction, just 1 degree, you will not land up in Delhi. You will land up in Guwahati. That's the power of 1%. So the definition of quality, of course, Mr. Mohan has very rightly said that keep improving. Yes, quality is meeting and exceeding your patient's expectations.
Ma'am, I think if we keep ourselves in the patient's shoes and try to understand from his point of view, I think at every step we can improve further. Maybe
Completely,
right
I
from the
agree.
security point of view till he comes out, exits.
Absolutely.
That applies for OPD as well as IPD.
I just gave you an idea of OPD because that's easy. Almost all of us have our OPD set up. So and we all have visited OPDs. So we have an idea what are the expectations we have from any setup. And the first step, as you said, if you keep yourself in the patient, this thing, it's empathy. And what I made you do was process mapping. Process mapping is a tool where you actually visit the whole process by being there in the real life situation. And do it yourself. Sometimes sit in the OPD as a patient in your own OPD in the waiting area and look at the surroundings, the wall, the windows, the cleanliness, the presentation. You'll immediately get an idea, oh, my place is not well kept. Because when we are sitting in this chair, I can see here, I cannot see on this side. And when I cannot see on this side, I can't see my back. So sometimes it's important to sit at a different place and look at things from the other person's perspective. And there's a huge learning in that. There's a huge learning in that. So any questions about whatever we have discussed in terms of patient's expectations? Yes, Dr. Seema, I agree. The technical definition is quality is conforming to the standards. I absolutely agree. I believe in giving definitions that help you work on yourself. So that's my, you can say, weakness or strength. So that's why I said, if you can meet and exceed your patient's expectation, you're moving towards quality. And it's a journey. It's not a destination. We all know quality is a journey. It's not a destination. Today, what is best may be absolutely out of, the question in the coming years. No? So you will have to continuously, I think that's one cognitive flexibility we have to, adopt. And if you go by what psychologists across the world are saying, to start with, we said IQ is the deciding factor of your success. Then a study by Daniel Goleman, who is the father of emotional intelligence, it says 85% of your success comes from your emotional intelligence, which decides your communication and interpersonal skills. There's a new concept. Besides intelligence, besides emotional intelligence, you require AQ. That's a new thing that's coming up. And what is that AQ? Agility quotient. How flexible you are. And COVID has taught us, these 2 years have taught us, those who were flexible, they could have float. Others had to go out. So please be open to, to try new things, experiment new things. What you may know may be right at one point of time. It may not be right now. It may not work at all right now. So why not adopt? Sooner you are ready to adopt, better your functioning will be and more successful you will be. Okay, so any questions about patient's expectations before we move on to the presentations by 3 participants? Does that change some perspective about patient's expectations perspective? We do get an idea that, yes, I think we need to keep the patient in mind when we are, designing our services, delivering our services. It's not me and I, it's them for whom we are working. And if we can keep them in the center, so that's where a lot of now discussion is about patient-centered services, patient-centered consultation, patient-centered interview, patient-centered hospitals. Yes, Dr. Seema, expectations increase every time, and that's the beauty. That's the beauty, so that we are not dead, so that we are not absolute. If you keep an eye on the changing expectations and if you keep upgrading, it's a growth of your setup and your personal growth. So every time I read your feedback, I change my way of delivery. I integrate a lot of things in my session. If I think, oh, my audiences are expecting a lot from me, why the hell should I meet those expectations? You will throw me out of this room. Design thinking is not part of patient expectation. I integrated for the reason the kind of clientele I'm getting in this program. If it was just a bunch of trainers, I would have not talked about design thinking at all. That's not a relevant topic at all. But seeing my clientele, if I can't give you a solution, I'll fail in my duty in delivering a talk about patient expectations. I'm telling you, yes, patients have expectations. You'll say, what do I do with them? They have so many expectations. I can't handle them. It's mind-boggling. But I'm giving you a tool, a scientific tool, well-tested tool, being taught by some of the elitist, institutes across the world. And use that tool in your own setup, and you can do wonders. Thank you. Any other question? Any thoughts? Any points we wish to add?
That is how telemedicine and teleradiology concept has come, keeping in mind the patient's expectations and the concern for patients or satisfaction, so that they don't need to come all the way to the hospital. It can be done remotely, and the reports are
imagine
accessed.
how the remote services are going to be, looked after. See, we normally talk a lot about, the services in the remote area. We all want to be specialists and super specialists, but nobody wants to go and work in the remote India. So how will we serve them? Now imagine if we are able to establish these services in a very structured manner, how many people will be really benefited? I went to Bihar almost like 3-4 years ago, I'm talking before COVID time. And there they told me that we are coming up with the digital, health. And we are having a kiosk. Another thing, it was in the Apollo, I had a meeting. So one doctor, he said, I'm a cardiologist and I'm seeing 300 patients every day. I said, how come? How is that possible? And the setup he explained to me was so beautiful. He said, I have kiosk set up, around 100 kiosks set up in different remote areas. And I have a technician who is sitting there. Any patients with any cardiac symptoms would come there, would get the ECG done. ECG will be immediately sent to a set of my doctors who are sitting in this central area, who would, read the ECG in case if the ECG is okay, and then he would take the other details from the patient, the signs and symptoms. If everything is okay, he will write the medicine as per the requirement. And in case if that requires, cardiac consultation, the patient is referred to me, and then I interact with the patient. This is nothing but design thinking. How many of us could think that I can serve rural area sitting right in the office where I am? Yes, Dr. Himanshu, I agree. Non-invasive and minimum invasive. Now तो robotic surgery आ गई है, तो invasive भी हो रहा है. It's not just about. So, but yes, the patient's welfare has to be kept in mind, and sky is the limit. I wouldn't be surprised tomorrow I get to hear even the sky is also not the limit. We can even go beyond sky. Okay, so if there are no more questions, I think we'll go ahead with the presentation. Dr. Richa is ready, Dr. Praveen is ready, and Dr. Seema is also ready. So who would like to present? Let me first of all share the feedback form about this session so that we can complete the feedback formalities for this topic, and then we move on to the presentation. Give me 1 second. So I have shared the feedback form in the chat box. Spend a minute and complete this so that we can move on to the presentation. So I have received 7 responses. I am waiting for others to submit.
Ma'am, low point of this session and saying option 1.
I know, I think there is some confusion about this question. Every time I change the setting, it goes back to the same setting. Let me check. It's supposed to be, actually it's supposed to be a short answer, but I've changed the setting and it goes back to the option 1. I've changed once again. See if you can add the answer.
No, it's not accepting.
Not accepting? So
should I submit without?
Yeah, please. So I've received 13 responses. I think 2-3 more people are still to give. So Dr. Puneet, there's a small clarification I want to seek from you. In the response, you have written 1, rate the session as 1, 1, 1, 1. So is it that you want to, is it the lowest rank or the highest? Because in this case,
I think one is a star. I think it's obviously the highest rank.
I got really confused. I said, has it been really very, disappointing to you? Because
No.
Thank you.
Sometimes
Thank you.
the forms, you
a little confusing, yeah. See, actually, when we give rating, I think 5 is highest when it comes to the. Actually, it's written also on the in the beginning.
Yeah, I didn't see that.
Yeah, it's okay. It's all right. Thank you for clarifying, because it really kind of surprised me that has this session been really very disappointing for somebody. So I really.
But in the end, I have written it's a good session.
Thank you. Thank you.
That's the communication gap actually. So you should speak that 5 means this before giving us.
So it is written in the question that 5 is excellent and 1 is like unsatisfactory. But then I know at times when we are answering, we don't get to see everything. That's perfectly all right. So I think I will request to start with Dr. Richa. Okay.
Yeah,
Dr.
I'll do that.
Okay. So I'm giving you the rights to screen your share your screen. And you can start with your.
Before I start, I must thank Dr. Puneet Gupta, because initially I was finding it difficult to present and I requested him and he agreed, but then I could make it up. So I'm sharing.
Thank you.
Is it visible?
Yes, it is visible. Yes.
I just want to put forward that this is from the video which my first year students have made. The National Medical Council has come up with an ATCOM module and we have given them, to make a role play.
I didn't understand that.
There's no sound, Dr. Richa.
I'm checking.
Not able to find it. No.
No.
So, should I play the?
Yeah, please do.
Give me a second. Yeah, give me a second. I'll play it from my side. Let me try. I hope it works. Yeah.
Is it audible now?
No, not yet.
Then I think
Yes.
that's better you should.
Is it audible?
There's no video coming.
No, I'm trying to see if I can, start the video from my end. Give me a second to copy paste. Still not able to copy. Really sorry.
Okay, I'll just present the video. Sorry, the PPT.
Yeah, you do it, and meanwhile, let me see if I can. Yeah, I could copy now. Yes, give me a second.
Okay.
Yes, I could copy. I've copied the link, but I'm not able to start it.
Okay, I'll just explain.
Yeah, try from your side maybe, because I'm trying.
No problem.
Yes, we are able to do it. Yeah.
Okay.
Sometimes it's very tricky.
We are going to talk about a situation where a doctor is facing language problem in his newly placed area. So let's see how doctor faces this new challenge.
नमस्ते माता जी, आइए बैठिए।
राम राम डॉक्टर साहब।
हाँ माता जी, अपना नाम और उम्र बताइए।
नाम गीता देवी है, हमारी उम्र है 40।
तो बताइए माता जी, क्या तकलीफ है आपको?
डॉक्टर साहब गोडा घना दुखे मारा, गोडा कमर आगे खड़ी नहीं आवे। हम बताइए जावड़ो को में किसान परिवार मुझे को जाओ में और बाजरी और खेती करनी पड़े चमसे टाइम में जने तो इतो दुखे खड़ी नहीं आवे। गोडो आगे कमर आगे बेजी नहीं मारू तो एन डॉक्टर साहब रात में मुंह जने नींद नहीं आवे, पकताड़े नहीं बोले मारी तो कई करूँ उम्र भी बुढ़ी होगी, काबर सेवा करे नहीं है, धंधो करना पड़े आते।
माता जी मैं आपकी भाषा समझ नहीं पा रहा हूँ, कोई आया आपके साथ? Sister, her attendant, Mr. Parekh, must be in the waiting room. Please call him. राम राम डॉक्टर साहब। जी राम राम, बैठिए। वो मुझे माता जी की भाषा समझ नहीं आ रही है, आपको हिंदी आती है? ना सर, मैं पढ़े लिखे को नहीं, ना तो देवी स्कूल गया। अच्छा, तो दिक्कत होगी। सिस्टर आप ऐसा कीजिए, गुप्ता जी को बुला दीजिए। यस सर। आइए गुप्ता जी, आप तो यहाँ के लोकल है ना, आप बता सकते हैं माता जी क्या कहना चाह रही है? हाँ जी सर। हाँ माता जी बताओ, कई तकलीफ है? अरे हमारे गोटा घना दुखे है, कमर भी दुखे बेटा, पगता यूं भले रात में नींद को आवे। सर माता जी बोलना चाह रही है, उनको घुटनों में दर्द है, कमर में दर्द है, उनको एड़ियों में जलन होती है और रात को उनको अच्छे से नींद नहीं आ रही है। अच्छा अच्छा अच्छा, समझ गया। देखिए माता जी, आपके शरीर में कैल्शियम और विटामिन की कमी लग रही है, जिससे जोड़ों में दर्द हो रहा है और थोड़ी थकान भी महसूस हो रही है आपको। मैं कुछ टेस्ट लिख रहा हूँ, आप उन्हें करा लीजिए, और तब तक आपको आराम रहे उसके लिए मैं कुछ दवाइयाँ भी लिख रहा हूँ। उन्हें टाइम से लेते रहिएगा खाने के बाद, और टेस्ट रिपोर्ट के साथ मुझे 5 दिन बाद आके मिलिए। So as we can see, the doctor took help of his staff. In real life situation, we can either do the same, or to be a more generous doctor, we should try to learn the local language. Our group consists of Shashwat as doctor, Sharda as patient, Shobhit as staff, Shivash as relative, Shishir as narrator. These doodly videos are better than any of the other videos I've ever made. And they took me like a quarter of the time to make them.
What is this?
It's almost like I paid a real life animator to do
I
that.
think we should
like all the images
pause
that are
that.
Yeah,
Dr.
yeah.
Indra, if you can pause that.
Absolutely, yeah. I've done it. Yeah. Please go
Yeah,
ahead.
hello everyone. Actually, this was from the COVID era when everybody was, if all students were at their home. So if you can have a look, that everybody is at different places and they're not trying to make a video, a role play out of it. So this is what really happened during the COVID era, to explain how the language barrier can affect the doctor-patient relationship. Now, as far as role plays are concerned, the how do you define role plays? There can be a lot of definitions regarding role plays, but simple definition is acting out a defined character in a mock situation. So role plays can help make classes or workshops dynamic, energetic, and actively involve participants in teaching learning environment. Planning of role plays also serve as a good review of some course material. This is at Government College Amritsar. We planned a communication skill workshop, and this they are trying to do some, uh, whisper role play they are playing. It's not moving. Okay. Enactment of role plays, instructional strategies that are lively, educative, and encourage participants to actively participate in the process are better than an uninterrupted exposition of information. It allows participants to practice their communication skills in a conducive environment. Improvisation is not only entertaining but extremely useful in understanding concepts, and a hands-on experience is a lifelong experience, the best teacher. So role plays by participants, you can give them concepts in advance so they can develop and practice them. You can give them a semi-structured script so that they should not go astray, especially if they're younger, students, or if they are elder adults. You can, tell them that this is the basic objective and they can plan their own role plays. Discuss on how they will deliver it. The role plays also serve as assignments which can be reviewed, graded, and assessed. Need to be carefully designed, thoroughly detailed, facilitated, and objectively debriefed. I'm briefly talking about the National Medical Council. It has come out with curriculum-based medical education program from 2019 batch, and an ADCOM module has been added. We talk about ADCOM, then it's attitude, ethics, and communication. So communication is really, really important here, and role plays do play a very, very important role as far as teaching the soft skill and communication are concerned. So what can be the disadvantages and the advantages? There is active participant, energizing and fun, development of creativity and teamwork, long-term learning, time efficient, experiential learning, delivers complex concepts in simple manner, use both verbal and non-verbal cues. Disadvantages can be participants may be shy or reluctant, can be threatening for some, may become too much fun and disrupt the task. Objectivity may be lost due to fun. Participants may not convey the message appropriately. Observers may take sides based on their preconceptions. Do's and don'ts: design appropriate scenarios according to the objective, plan and set aside adequate time to conduct and debrief, set ground rules, be specific in description, ensure participants are comfortable, ask participants on what went well and how could they make a difference, mention what went well and what needs to improve. Don'ts: do not rush to rescue the participants, let them find their way. Don't interfere when role play is in progress. Don't be on fault finding. Don't target too many learning points. Don't humor participants. So this is my own experience. This is a paper which was published in Advances in Physiology, and we enacted role plays. You can enact a role play in the class for Parkinson's disease. Can be a self-facilitator to understand the gates in motor systems. Role plays to enact communication skills, verbal and non-verbal. Like for the last paper that I discussed, there were 4 role plays regarding to the respiratory physiology, on celebration of party role play when we talked about how to perform the Heimlich maneuver, uh, and the drowning play to talk about different types of BLS, accident or a mannequin role play where we talked about how to perform the BLS, and doctor patient role play on to see how certain graphs or spirometer could be read by patients. So my own experience, that is all. We had some communication skills where how to enact breaking bad news, medical history, communication with vulnerable population and all. And thank you for the positive time. We'll keep it short. I hope, Dr. Indo, I could finish in time. Thank you.
Thank you so much, Dr. Richa. Thank you. So if you could stop sharing the screen.
Yes. Yes.
Thank you.
Thank you.
So, friends, role play is one of the very, established pedagogy of training. You will really like it, and you'll find it very useful, especially very difficult concepts. If you want to really, showcase through role plays, you can do. For example, this video done by the students to show the, language as a barrier and how you have to, overcome this barrier. So if this was done as a role play, probably people would have been more engaged. Of course, video is quite enlightening, but had it been a role play, then people would have been more, engaged in this. So we'll be doing a lot of role plays in the coming sessions, handling difficult patients and handling aggressive patient party. How do you resolve complaints? How do you disclose medical error? How do you break bad news? All this we are going to do through role plays. It's a wonderful tool to be used in any group activity. It really engages your audience. So I think Dr. Richa has really explained everything very well when it comes to advantages, disadvantages, do's and don'ts. So, keep this in mind wherever you can bring it, even in your own clinic, for smaller things that you want to teach them. If you make them rehearse through role plays, they pick faster. You will really find it useful. So, any questions about what Dr. Richa has covered, if you wish to ask anything? Okay, so if no questions, I will request Dr. Seema to talk about her topic. So time is 10 minutes. Please keep in mind so that we can finish not very late. It will be slightly late, but keep in mind that time point. Thank you. Go ahead, please.
Okay, I'll just share.
Yeah.
It's coming, like it can be seen.
Yeah, but you have to go to the slide show board, no? That will be better.
Slideshow.
Yeah, that will be better.
Yeah. Is it okay now?
Yes, it is fine.
Yeah.
Thank you.
And the topic that I have chosen is Socratic questioning as a way of facilitation. For me, it's a very, very new term, actually. So I just Googled and saw and read few of the articles and saw it like how it is being used. So I don't know how much I will be able to make it, understandable to everybody, but I have tried a bit. Okay, there you can see two pictures like. These are a very familiar situation. It's a waiting area of a hospital. You can see two areas, like in the left, you can see something which is, totally, kept very nicely. Properly done. People are sitting nicely. And it looks a very disciplined area. And towards the right, you can see that, the wheelchairs are there, the bed is there. The people are sitting. It's all crowded and all. So here, when we use, Socratic questioning, then what I have seen is we go into like, which way do we use the questioning part of it? So if we go for closed questions, like we would be asking, can you relate to this picture? Any one of you, can you relate to this picture? Like, or when we go for, say, yeah, I'll not keep it very long, so I'll only do it now. So like when you go to the open question sort of a thing, then like, what is your take on it? It's open-ended. You can, make it either way. Like you may take up the right-hand side also, or you may take up the left-hand picture also and go for an explanation of it. Then whether, if we go to the right picture, like, the probing questions, say we want to do a study out of it. Say it's a management study and it's an operational study. So we would like to raise some questions, like we would like to see some questions from the audience or from, say, the group, whoever is taking up the study, like how to, make it better. Which are the sore points of the entire process? Where are the process failures and all? So these will come as questions in the Socratic questioning system. So what is Socratic questioning? It is a disciplined questioning that can be used to explore thought in many directions and for many purposes. So we can the questions can be put up where we would do some infrastructural changes. Questions may come up where we can do some process changes. And it may come up as, the manpower changes, and where we can set up the flows and the processes differently, where the entire look can be changed. So the advantages of Socratic questioning will be like, the questioning will be done in such a manner that you really need to think. And it gives you some creative thinking skills, like, you will think whether we should go this way or that way, whether the flow, if we can put up, say, the chairs we put up very badly in the picture towards the right, where there you can see overcrowding, there the thinking will come whether we can keep up the, chairs, say we keep the 2-seater ones or the 3-seater ones or the waiting chairs. Do we put it in a linear manner or do we put up in rows? And where do we keep up the wheelchairs? Which should be the route of traveling? How do we route the wheelchairs? Which way it should flow? Which way should the sitting be? And how the waiting patients should be facing, whether they should be facing each other, how the chairs are to be aligned. So the questioning should be coming in, the questionings are put up in such a manner the thinking comes up. So the advantages are learning how to be challenged and what to do when we are challenged. Like, so I'm not being able to put it up in a proper manner, how to question it actually. I think ma'am can help it at the end. And here the advantages are that, you get in-depth into the problems of an issue. The disadvantages are, say the participants do not question, so your thinking will not be coming up. Which way do you think to solve an issue? And many a times, like due to fear of public speaking, I mean, people do not like to speak. So that is also an advantage where, the thinking will not open up. And many a times it happens that only one or two persons are speaking. So like the other people may lose interest because it becomes a one-to-one conversation that time. And it is also that too many ideas will come up from too many people, and then nothing is right or wrong. So going to a conclusion becomes a bit difficult, and it is sometimes difficult to handle multiple responses together also. So the do's will be topic to be discussed should be a familiar one. Say in a medical setup, a healthcare setup, for say healthcare people, if it comes to a management level, we will see the processes, we will see the flow, the infrastructure, and how to improve it, and what to improve, and what more new processes can be put into action, and how to improve the satisfaction of patients. So, and the topics should be, not too controversial actually. So the don'ts come that we must not pick up topics for Socratic questioning, like which are sensitive topics, like politically sensitive or religiously. I mean, those topics are not good to be discussed in this manner. Like, so this questioning system, I mean, it can be used to explore ideas, and because everybody has to participate and everybody's ideas are suited for here, and to get the truth of things, then to open up issues and problems, because these are all open-ended, it is open to the audience, then to uncover like assumptions, analyze concepts, then distinguish between what we know from what we don't know. Because people will put in ideas, where from only we will bring up a concept and take out a solution. If there is any issue, it is put it up in that manner, to follow out logical implications to thoughts. And usually, like Socratic questioning, it is done, it is used by law study students and all. Say the lawyers are also using it. So like leading questions are put up sometimes, or sometimes, open-ended questions are given. So nothing much to say. Actually, I found it to be a bit complex. I mean, to understand it, I think I'll have to go through it more. So ma'am, if you can throw some light into it. Thank you.
Thank you, Dr. Seema. Thank you. If you could stop sharing, we could quickly have 2 minutes discussion around it. Yeah. I completely understand Socratic questioning is a very difficult pedagogy. Unless you're really aware or well-versed with the way to ask questions, then it can be extremely challenging. So Dr. Seema, congratulations for actually making an attempt to cover this topic, because it's a difficult question. I absolutely agree. So friends, just yesterday, I was taking a session for AIMS Jammu. So the session was for the faculty. The topic of the discussion or presentation was, how do you, communicate with students. So this was for the teaching faculty. So the topic was essential communication skills with students. The whole session I designed into a couple of questions. I did not make any presentation on it. The first question was, what are the challenges you are facing dealing with today's generation of students? That was my first question. Second question, why are we facing these challenges? Third question, what has changed in this generation? What is new in this generation? Fourth question, what do you think, from the understanding that we have about the new generation, that is millennials and Generation Z, what will work and what will not work? These 5 questions I just put up to the audience. The answers came in the chat box, and the whole session was a very lively discussion. It was nothing but Socratic questioning. I did not use any PPT because I knew just one slide that I showed was what are the characteristics of this generation, whom we call millennials or we call Generation Z. That's all. Rest everything came out as answers from the participants. So that's the power of Socratic questioning, where you, especially when you are dealing with people who know, it's just a matter of facilitating and playing a role of a catalyst and getting the information flow from the audience. So it's a beautiful technique. I am not asking you to start covering the whole topic as a Socratic questioning style topic, but anywhere if you will integrate this in your way of doing a program or a session, you'll find it very thought-provoking. The whole idea about Socratic questioning is that you are not providing answers, but you are asking very intelligent questions. Questions to which you already have the answers, but you are not giving the answers. You are just putting the questions and allowing them to answer. And through that journey, they will get to know the answers that will be within them. And the beauty of Socratic questioning is it's a collective vision that comes out when you ask questions to a group. So use this as a tool in your sessions when you are going to introduce a new topic, a difficult topic, a topic where you want to showcase them that probably there are things that we are not doing right, or probably there are things that we don't know and we need to understand. And then if you add a surprise element of your knowledge and your understanding, that really engages the audience very well. But thank you, Dr. Seema. I think you did a good job and you explained about the advantages, disadvantages, do's and don'ts. I think that was really done very well. Yeah.
It was really interesting, ma'am, when I was going through the articles, actually. Yeah. Such a new topic.
Yeah. Especially who are into teaching, they should be actually moving on to Socratic questioning, especially with the students also. Don't provide them any information. Just ask them questions and let them answer you. And you will find wonderful answers from them. Thank you. Any questions about Socratic questioning as a pedagogy?
So can it be termed as basically to get thoughts from the others based on what we...
Engaging them, getting the ideas, getting more answers, getting new perspective from people, because people would come with different background, different experience, cultural background. So you'll get a lot of new ideas from the situation.
That will also help us to keep them engaged over the topic.
Absolutely. Absolutely. So anyone who is using it extensively, Socratic questioning? Anyone who is using it extensively? Use this as your way of even communicating with your team, rather than giving them solutions, giving them answers. Convert everything into questions. Ask them. You will have the answer with you, but let them first think and come up to you. They'll get involved with you. Thank you, Dr. Seema and Dr. So third session is by Dr. Praveen. Dr. Praveen, are you ready?
Yes, ma'am.
Okay.
Can I share the screen?
Yeah, you can share your screen. Yeah.
Ma'am, Apple has just given me a challenge. I need to quit and reopen, only then I can share the screen. Yeah. No, I'll quit and please accept me again. I'll just
Sure.
Okay.
See, the idea is that if we become aware of the different pedagogies available, we can use it as and when we think it is appropriate to use them. So that's the whole idea of, making all of you do small presentations on different pedagogies.
Ma'am, can you see my screen now?
Yes, it is visible.
Yeah, good evening all. As you know, I'm the last speaker for the day. So actually, Dr. Siva has given a very good session about the Socratic question, and ma'am had also explained. My topic is relatively more simple. That's why I think ma'am kept me for the end of the session. It's about rapid fire questioning. It's a very simple form of questioning where you don't give your audience a lot of time to think like Socratic questioning. Things. You just ask them to quickly answer the first thing that comes to their mind. I mean, just to be more interactive, can I have 3 volunteers? If you can.
Please raise your hand. 3 volunteers, quickly.
Yeah, Dr. Himanshu, sir, I can see you. Yeah. I won't do like ma'am, send you away and then give you a surprise when you come back. Dr.
Okay.
Vijay and Dr. Mohan, sir. Yeah. So I'm just going to start, since Dr. Himanshu came first, I'm going to ask him a few questions. Himanshu sir, do you have pets? No. So I did a bit of lip reading. Yeah. So can you unmute your mic?
Please unmute your device.
No. Do you? No. And do you have kids?
Yes.
Do you live in your native place?
Pardon?
Do you live in your native place, hometown?
No.
No. Okay. So can I move ahead to Mr. Vijay Kumar?
Sure.
Yeah. Vijay Kumar, I'm going to give you a few hard questions. What is your deepest fear?
Okay. If I cannot live to the expectations, my expectations.
Okay. What is your biggest flaw?
Not able to use my potential till now.
Excellent, sir. Which moment would you most like overdo, like from the past?
My childhood days.
Okay. Excellent, sir. So, Mohan, sir, coming to you, I'm going to ask you a question with two options. So either it's what do you like? You like work more or play more?
Play.
What do you like? Money or happiness?
Money.
Cats or dogs?
Dogs.
Okay. Morning or evening?
Both actually. You want me to choose one?
No, which comes first?
Mornings.
Mornings. Excellent, sir. So I've just given you a demo of what are different types of questioning. What I had asked Dr. Himanshu was yes or no questions. So what have I learned from him is he's married, he has kids, and he does not live in his native place. So a few things which I didn't know about Dr. Himanshu a minute or two ago. Another thing about Vijay sir is I know he always wants to fulfill his potentials, and he really wants a nice child. I mean, like childhood is something which he really thinks about, and so these are things which we can learn from people in rapid fire. It's a way of interacting with your team, a part of team building. And about Mohan sir, a few things I learned is he's a very jovial type, and he likes dogs. He likes a lot of play than work, and definitely likes more money than happiness.
Money brings me happiness.
Money brings happiness, yes. Okay, so just about that, and few lines about rapid fire questioning. Their rapid fire questions are instant response prompts that encourage players to blurt out the first answer that comes to the mind. These types of Games are a speed up version of icebreaker questions and act as a fun, fast, and mindless way for teammates to get to know each other. So the advantages of rapid fire questioning helps in team building. It moves fast, does not require much time. It's a great way to learn lots of personal information about a variety of people in a very short time. It's a disadvantage is a very informal activity. It cannot be used in all settings. It should be assessed properly before using in a given space. And for the activity to be a success, definitely audience participation is mandatory, unlike role play and other things, storytelling. And the few tips is make it enjoyable, add humor, make the pedagogy more interesting, and they keep the question short and in simple language. Do not ask embarrassing questions. Don't ask culturally controversial questions, and do not use complicated languages. Thank you. Yes, ma'am. Thank you, ma'am.
Thank you so much, Dr. Praveen, for creating interest, and everybody was excited what questions are going to be asked and how they will be answering. So again, I think this is a new pedagogy that Dr. Praveen has shared with us, and that's another good way of creating interest and engaging your audience. And there are many ways to to start with. Are you all using this anywhere in your way of trainings, in your way of?
I think not only in team building, but also, to assess people, or say after this workshop, Dr. Indu gives us, a few questions and start asking questions as a rapid round, then I think that is also a wonderful learning opportunity, and beyond team building, of course.
Of course, yeah. So the idea is that we get to kind of, create more ideas and more thoughts around things. So when you have, so you could even ask rapid questions about quality or communication, or on other topics also. Of course, here it was more to get personal information. You could actually even avoid this and ask questions about the topic that you are going to give or to talk about, so that they would get engaged, and they'll also understand, okay, I didn't know about this. So but definitely, Dr. Praveen, it was an interesting and engaging activity that you did. And you brought in a lot of variety of questions. I think that was very interesting. And you classified also that these are hard questions, and these are deep questions, and these are superficial questions. So absolutely, we have to avoid deep and embarrassing and hard questions, because it can put spotlight on the people and they may not feel comfortable, especially when we are still building rapport with people. It can put them off. But wonderful presentation. Any questions about this, or any points if somebody wants to say?
He actually put me in a spot.
Rapid questioning, it is just asking questions in a fast manner, but there
Absolutely.
are a lot of other things which are there, like yes or no questions.
Yeah.
Different types of things which are there. So thank you, Dr. Praveen, to bring it to our notice.
Yeah, he's brought variety to it. Yeah.
Thank you. Thank you.
Yeah, Mr. Mohan, you were saying something. Please go ahead.
No, that was on a lighter note.
Okay, it's okay. I thought you had something.
I was saying he put me on a spot with my answer.
Sorry.
So
There's something about. No, it was momentary, because something about money was in my head since morning.
Oh.
And that would have definitely got me happiness for the day.
Sentence completion test is a proper psychometric test that we use to assess persons, subconscious and unconscious thoughts. And even slip of tongue is not something that happens, inadvertently. Actually, it also showcases your subconscious and unconscious thought process, and we use it a lot in psychometric testing.
Does it spell out the present status, or does it spell out your personality as a whole?
Could be anything. It could be both. It could be both also.
Thank you so much.
Answers collectively, because when we ask them to take a test which is say 20 or 30 statements, and when you complete all those statements, so it shows a trend. And you get an idea, pick through the person's mind, that what this person is thinking or feeling or experiencing, or what is the present, or it could even be related to past also. It could even be related to past.
Thank you so much. Thank you.
Thank you. So again, rapid fire is a wonderful way to engage your audience, to start a session, to in between energize people, and to also help them see what they know and what they don't know. Care has to be taken that don't ask any personal questions or deep questions or embarrassing questions. That point is something we have to really, keep very well. Yes, I completely agree. It was a wonderful presentation. So I think with this, we come to the end of today's session. I know we are past 20 minutes, rather 25 minutes, but I think that's going to happen because presentations also take almost like 15, 20 minutes. So around 45 minutes will go in 3 presentations, but I want each one of you to, present. Only one request that I'll say, please discuss your plan of presentation much in advance with me so that if we need to make some changes, we can, discuss them properly. We know what changes. If you do it at the last moment, and especially I'm in the opposite time zone, then we don't get time to connect and discuss it further. So please don't wait for your time to come. You can start preparing and discussing with me, and in case if you're done, then we can actually be clear that it is done. Second thing that I really want all of you is to come out of the habit of using PPT. Please do not read the PPT. If you're reading PPT, that means you're not prepared for your presentation. PPT should be there, but you are not going to read every word of the presentation. It should come as though you're talking to us, you're discussing with us, you're sharing your thoughts with us. That will really improve the impact of your delivery. See, this is a trainer program, so your training facility skills also should improve by the end of the session. So please do not read the PPT. PPT should have the key points, but what you are talking should not be there on the PPT. It should be altogether different, and it should look as though you are here. So the whole idea is we all practice here, learn from each other, and become better. That's the idea. So whoever is presenting in the next week, please get in touch with me as early as possible. Share your presentation and see what best you can do to your presentation. So thank you, everyone. I know it's very late for all of you, 10:30. It's very tiring and very, end of the day. So let's meet next week. And any questions can be taken next time, or in case if there's urgent, if you want to say something, we can take a minute or so before we close.
Thank you, everyone.
Thank you so much. Good night.